Thank you very much. So my name is Nuala Hampson. I'm pharmacy lead at CSH. So I'm really happy to be presenting initial insights into our project on medicines waste in care homes, reducing social and environmental impacts. This is a Q Exchange project, which is funded by the Health Foundation and NHS England. So it's already known that around £50 million worth of medicines is wasted annually in the care home pathway. This data is from about 15 years ago. It's a long-standing systems problem. So we really wanted to look at this problem through the lens of sustainability. So we wanted to explore the factors which contribute to medicines waste. We wanted to look at the environmental and social impacts. And we ideally wanted to come up with some practical solutions and recommendations that we would be able to share widely. So we recruited 4 hubs as part of this project. So each hub consisted of one care home, the GP practice prescribing for that care home, and the community pharmacy dispensing medication for that care home. We created teams at each of these hubs with at least one key person from each of the sites in each hub. So we encouraged them to create team names because we really wanted to engender good communication and a team approach from the beginning. So we used the SusQI approach to explore the issue of medicines waste in the care home pathway. We really focused on studying the system because we really wanted to sort of look in depth from this slightly different angle at the issue of medicines waste to see what we could identify in terms of factors contributing to this problem. So the teams spent quite a bit of time process mapping their processes. So this is just one example of sort of an overall pathway. You've got your care home here. Every month they order their medicines from the GP practice. The GP practice writes prescriptions and sends them to the community pharmacy. The community pharmacy delivers the medicines. So that all makes sense and seems relatively simple and straightforward. But once we started to look into this in a bit of depth, there was a huge amount of complexity within this. So I don't expect you to read these process maps. I'm just sort of showing the sort of level of complexity that we're dealing with. So first of all, each of the 3 sites had their own sort of complex pathways. And then there were sort of different factors that further complicated matters. So firstly, there was the regular monthly ordering of medicines by the care home. But then there were interim and urgent orders, which in some cases happened every single day, in some cases more than once a day. So there was a sort of a separate pathway for that. There were also lots of issues like cut-off times for prescriptions that contributed to the complexity. Also, the different models contributed to the complexity. So, for example, the clinical systems within the care homes and GP practices, different dispensing models. So one of our pharmacies used a robot dispensing process, the location of the pharmacies. So they ranged from sort of local pharmacy just down the road to a remote online pharmacy, which was over 20 miles away. So lots of different sort of factors sort of feeding into the complexity of this system. So we observed that the medicines pathway is really very complex, and the communication between the sites and sometimes even within sites was really difficult. So these 3 sites, the GP practice, the care home, the community pharmacy, they're all physically remote from each other. Everybody within those sites is working really, really hard and under constant time pressure, all aiming to achieve the same outcome, which is to get patients their medicines efficiently and on time and safely. But because they're not working together, they're not sort of benefiting from that sort of team working approach. And what we also found was that there was a lack of understanding of the different processes at the different sites. So people would be doing something at one site and not really understanding the impact that it might have at another site. So a couple of examples of that. For example, one GP practice was putting really helpful notes on the prescription that would have been really helpful to the pharmacy team. But the way the prescriptions were processed at that pharmacy, they didn't actually see those notes, so they weren't able to make use of them. In another case, one of the care home, the weekend staff, over the weekend, they were being really efficient and organised and going through all of the medicines and seeing what needed to be ordered and sending off their order electronically. And then on Monday morning, they were ringing up the pharmacy going, "Where are our tablets?" Because they didn't understand the rest of the process and the fact that their order needed to go to the GP practice and be processed and prescriptions produced, and then it needed to go to the pharmacy to be dispensed, and that would take at least 48 hours as an absolute minimum. So there was a real sort of lack of understanding and awareness of each other's sites. And again, that was really down to people's capacity, the fact that they work in separate sites and under extreme time pressures on a continuous basis. And then even within sites, we sometimes found different things happening. So this example is of two medicines waste disposal units in the same care home, but in different sort of wards within that care home. So on the left-hand side, you can see on this ward, they were throwing everything into the medicines waste bin, packaging and all, whereas on the right-hand side, you can see that they were popping the medicines, the tablets and capsules out into the disposal bin. So sort of different practices happening within the same organisation. So in terms of action, we recognized that we needed to acknowledge that complexity and try and enable communication. And actually getting together in the workshops as part of the project really created a great opportunity for key members of staff to communicate freely and start to form good working relationships. In terms of sort of actions, they went forward and sort of put in place formal, inclusive methods of communication. And sometimes this could be as simple as a secure NHS email group that included all three sites. So importantly, often the community pharmacy was left out of that communication and they didn't know what was going on, and that sort of created queries and more time, etc. So sort of having these agreed methods of communication really saved a lot of time. It meant staff weren't having to ring up the GP practice on the sort of regular public phone line, you know, blocking up the line, sitting on hold for ages, taking up staff time. So just some sort of really simple communication solutions. Another observation was around the medicines waste and how it's managed. So no one is really accountable for the medicines waste. It's not monitored or counted or weighed routinely. The cost of disposal is separate and it's not really taken into account when you're thinking about the cost of medicines waste. So all of the care homes log their medicines waste routinely and in detail because they have to for CQC, but actually nobody really did anything with that information. Staff receive mandatory training on medicines and medicines administration in care homes, but we realise that they receive nothing on reducing the risk of medicines waste or the environmental impacts of medicines waste. So there's a real gap there in the training that care home staff see. And the other thing is that prescribers never see the waste. So the GPs, the non-medical prescribers, they never actually see this waste. And I think as pharmacy professionals, I think we're a little bit immune to it because we've been seeing it all of our lives. So we started to take lots of photos to kind of make it more visible so people could see the extent of the problem that we're dealing with. So again, the actions here were really to raise awareness of the extent and the impacts of the issues, and then to see, you know, what could we do to actually reduce the generation of that waste. And a lot of that was around reducing unnecessary activity around interim requests and urgent requests, which weren't really urgent and could have been dealt with in the sort of more routine sort of monthly sort of process. Obviously, one of the key outputs of this project will be for us to develop some education and training, which we'll be doing over the next couple of months. So then in terms of sort of measuring impact, we sort of attempted in this sort of very short time scale that we had to do some measuring of data. So when we were looking at the environmental impacts, there's obviously the carbon footprint of the medicines, which aligns with the cost of the medicines, but we also recognise that delivery of medicines can be a carbon hotspot. So particularly in cases where the pharmacy was very far away and there were multiple deliveries, we actually found in one case that the carbon footprint of the delivery of the medicines was greater than the carbon footprint of the medicines themselves, which kind of blew my mind. The issue around the segregation of medicines waste and sort of training staff and what does and does not need to go in the medicines waste bin. And also recognising that disposal of some other sort of bulk items like SIP feeds and dressings, etc., there was variable practices going on there in terms of where that was being disposed of. Cost of medicines is really quite straightforward to measure, but we also identified that identifying the cost of waste disposal is really important, and staff time. So the really significant social impact was staff time. Now, this was really difficult to measure as staff were simply too busy to log everything that they were doing, but it was really clear from the number of entries on the medicines waste log and from the qualitative data on our staff survey that time is wasted at every single site, ordering, issuing, dispensing, checking, delivering, logging medicines, which are then thrown away. So completely kind of unnecessary activity that's taking up lots of time. And of course, that's more stuff going into incineration, which doesn't need to be going into incineration. So the individual sites have gone away and sort of implemented lots of individual actions. Our sort of wider recommendations are around plugging that gap in the training for care home staff on medicines waste and its impacts, developing some recommendations around the accountability for medicines waste and the active management and monitoring of medicines waste and its disposal, and then utilising policies that are already in existence, like bulk ordering and homely remedies, to help care homes reduce the generation of medicines waste. So I'm going to hand over now to Danielle Lewis. Danielle is the accredited pharmacy technician at St Mark's Pharmacy in the Gloucestershire team, and she's just going to give us her perspective from sort of doing this work on the ground. Thanks, Danielle.
Just to say, we've got just a short amount of time, Danielle, if that's okay. Just a minute or so, thank you.
Yeah, you are fine. So yeah, that is no worries at all. So from this project, we learned about the extent of waste that our care home was dealing with. Unfortunately, we didn't get to see this because they use an outside contractor, so we didn't see how much medication was actually being wasted. With this, we also learned that not everything that the care homes were requesting was urgent. So we were doing daily drives of a 19-mile trip for non-urgent items, which obviously is a massive carbon footprint. We also found out communication, as you should know, is very much key. And if you don't communicate, we're going to automatically think that everything was required urgently. So that's why our deliveries went out daily. The challenges was time. Some monthly orders took us a day to be able to process. Sometimes it took a lot less. But this, again, was due to communication. If we're not told what is needed and what is required, majority of the time before this project, it was a guessing game. Next slide, please, Nuala. Since we've taken on this project, we have reduced our daily deliveries. So we were delivering 5 times a week. This has now gone to 2 times a week. And this has improved with communication. Between the care home and the pharmacy, as we are now told what's urgent and what isn't urgent, we can reduce our daily delivering. They have 2 designated days that they do get delivered on, but if anything does come through for end-of-life medication or an antibiotic, that is when it's automatically sent out as an extra delivery. With our monthly ordering, the prescriptions are now being more streamlined. So instead of having to order multiple times in the month, you can order at one time, everything gets delivered at one time. So it would only be acute prescriptions needed for those patients if required, not multiple items throughout the month, such as diabetic needles, creams, dressings, so that they would have it on site always. Another thing, like Nuala mentioned, more realistic expectations on turnaround of prescriptions. Yes, people would order on a Sunday. We would come in at 9 a.m. on a Monday, and they would expect their prescriptions to be delivered by 1 o'clock that day, which unfortunately cannot happen. We do ask for a 3-day turnaround for the GPs to be able to do what they need to do and for us to do what we need to do to be able to get that out. The successes from this project, we have learned that we have to communicate a lot better between 3 sites. And the team in the pharmacy have also become a lot better with duplicate prescriptions. We do know what comes through. And if we do see duplicate prescriptions coming through, we do question them before they get sent out to the care home to prevent waste in that way. We communicate a lot more with the GP surgery, more with the pharmacists to figure out what is required and what isn't. And if a interim dose is required, not a 28-day, we will get those prescriptions changed so that the care home has the exact amount required instead of items going to waste. Because, like I said, we don't actually see what they waste. We don't get told, unfortunately, because we don't have their waste coming back to us. So we have stopped a lot of prescriptions going out. This is something with the communication still needs to be worked on. We still are up against it with communication, but you need to work on that daily. Unfortunately, it's never going to go away. But as long as that communication is there, hopefully we should be able to keep preventing these prescriptions to go straight into a bin, and which is, again, saving money in all areas.
Right.
Thank you,
Thank you so much, Danielle. Thank you. And just to finish, got great survey from our feedback from our staff. Improving the communication really helped, but a lot of work still to do, and definitely raised awareness of the impacts, the environmental impacts of medicines waste. Thank you so much.